Okay, good morning, everybody. I'm sure you can all hear me. It is a pleasure today to be able to bring this subject up for us. It's something that I've been thinking about, and the real question is, what kind of impact, other than from our personal lives, has COVID had on our professional lives? And the next slide here that I'm going to share with you is a video that I was watching the other week. And it kind of caught my attention. So hey, it says Texas Roadhouse CEO Kent Taylor dies amid COVID-19 struggle. Okay. So here's the video. It's a very short one. He was a restaurant owner in the United States, and this is his what happened.
This morning, tributes from Louisville and beyond after the death of Texas Roadhouse founder Kent Taylor. The family and company writing in a statement after a battle with post-COVID-related symptoms, including severe tinnitus, Kent Taylor took his own life. The family going on to say Kent battled and fought hard like the former track champion that he was, but the suffering that greatly intensified in recent days became unbearable. Taylor leaves behind a legacy of giving back, helping to raise money for the Special Olympics and building homes for veterans. He also committed to funding a study to help military members dealing with tinnitus, the same inner ear ringing condition which he was battling.
Although we don't have a direct connection between COVID and tinnitus, we know that people with pre-existing conditions or conditions that might be caused by COVID, if they already have tinnitus, it can make that tinnitus worse.
So the important thing here is pre-existing conditions. If you look at pre-existing hearing loss via pre-existing tinnitus in the general population, the real question is, what does COVID do to somebody who has a pre-existing condition compared to somebody who does not have a pre-existing condition? Okay, that's the real question. All right. Oscar, you can let Saeed in from Ethiopia. This is going to be a little outline here of the of what I want to talk about. Oscar, are you there?
Yes, I just add him.
Okay, you can let Saeed in. Admit him to the lecture, okay?
Mhm.
You're not able to do that, or what?
No, I add him. It says that he's joining. Maybe he's struggling with the
Okay, got it. Okay. So I thought today we'd talk about current world statistics, variants of COVID, the impact on ENT practices, and the ENT subspecialties. All right. And then talk about a word that is new to the vocabulary. It's called long haulers. And then just a short discussion on myths. You got to realize one thing. We are in a process of current evolution. It's just over a year now since we've had the COVID outbreak. Research is coming in as we speak daily, by the minute. What we know is it's happening in real time. What we don't know, we'll know soon as time goes on. So we all are in this together. Any information we can share amongst each other, and feel free to, interject anything you might have, is all a new experience for all of us. So this was April 2nd, about 4 days ago, all right? And if you look at the chart here, it shows you various countries, total deaths. Just a second. It shows you the various countries, all right? It shows you the deaths and those that recovered. Of all the countries in the world, and we don't hear much about this, is the Czech Republic. The Czech Republic has about 2,500 deaths per 1 million people. You know, you go to United Kingdom, we're at about 1,900. US, 1,700. Brazil's numbers are even getting worse, but they were at 1,500 just a few days ago. Belgium, 2,000. Okay. Now, when you have countries with small populations like Czech Republic, I think has a population of 10 million, you know, you don't hear a lot about it. But Brazil's got 215 million people. They're kind of out of control right now. And they also have a variant that came from Brazil. You can see these other countries. Portugal's about as bad as the United States, but you're not hearing much about it. Okay. Um, Poland, 1,400 per million. Spain, as bad as the United States. So it's really important to get a perspective. There's really isolated countries that have a significant death per million population. Now, on the far side here, I thought it would be interesting to compare the Spanish flu to COVID. Now, the Spanish flu was 100 years ago, essentially. At that time, the population of the planet was about 2 billion. We're over 7 billion now. And the number of people that were infected with Spanish flu was about a quarter of the population, 500 million people. Compared to today, globally, we've got about 130 million people who've been infected. But look at the difference in the deaths. Spanish flu, there were 20 to 50 million, and we still really don't know the exact number of people who died from the Spanish flu. Whereas with COVID, as of 4 days ago, we just broke 3 million people that died globally. So there's a big difference in these two flus, the two viruses, I should say, the Spanish flu and the COVID virus. All right, we're hearing a lot of talk right now about COVID variants. Okay, what's important to note is that the COVID virus is an RNA virus, and by definition, RNA viruses mutate. We need to expect this. So for scientists to come out and say the COVID virus mutated, it's a normal occurrence, and we don't have to start freaking out about it. When these mutations occur in the viral genome, what happens is it manifests in the surface spike protein. And here you can see A, B, C in the bottom. And each one of them has a different configuration of the spike protein, because that's what's altering during the mutation. So the real question we need to ask ourselves is, will the vaccination that I got, if I got it, control a new strain? Another question we need to ask is, do we need new protocols with these new strains? And do the variants spread more rapidly? These are all questions that we have to ask ourselves, and we'll address those in just a minute. Also, is the increased infection rates, like right now in the state of Minnesota, we're starting to see a increase in COVID infections in the United States. We're seeing them in a population under the age of 25. And what we have to ask ourselves, so why are we seeing this? And one of the reasons is because the older population has been vaccinated, or let's put it this way, they've been in vaccination phase for about 2 months, individuals over the age of 65. And if you go back 6 months ago, the majority of people that were dying were people over the age of 65. We've controlled this. But we have a problem with the younger generation who initially was somewhat immune from the COVID virus, but now has not taken the precautionary measures to protect themselves, number one. And number two is we're dealing with these new variants, okay, which spread more easily. So I think there's a, from an epidemiologic point of view, we need to look at, the social behavior of individuals as well as the virulence of the virus itself. As long as the virus is alive and as long as it's going to be able to spread, it will mutate because that's the nature of the RNA virus mutation. And what we can do is what's been preached to us for the last year is continually wash your hands, social distance, wear a mask, and get vaccinated if you can. Because the whole goal here is to, through vaccination, is to reduce the number of people that are infected. If we can reduce the infection rate, we can reduce the amount of virus load and therefore ultimately reduce mutations. I thought this was a nice example. The green on the top would have been the Wuhan, China variant that was the first one detected. Many questions are asked, did it come out of the lab in Wuhan? Now, the World Health Organization sent a team over to Wuhan a few months ago. Some of these specialists who are virologists, epidemiologists, who are all affiliated with the World Health Organization, pretty much concluded that it probably did not come out of the lab, that it probably came from Western China through the bat population and infected animals which are sold in markets like Wuhan. So that's most likely the mode of spread was from the animal vector in the wilderness to animals, because in China they'll eat anything, monkeys, snakes, all kinds of exotic animals, bats, and it spread from one of those vectors to the human population. And you can see each one of these has its different name. The first one in yellow is called the B117. It was the UK variant, which was detected in November of 2020. And why is it of a concern? Because there's increased transmissibility and possibly the increase in severity of illness. In October of 2020, we had the South America variant, which came, South African variant, the B1351, which came from South Africa. And it is also has increased transmissibility and possible reduction in the vaccine effectiveness. However, it's not been proven as of yet. And then the last one came in just 2 months ago from Brazil, and it is called the P1, and it's similar to the South African variant in that it's got increased transmissibility and possible less effectiveness of the vaccine. Now on the top here, we have the UK variant. You can see there's a big red dot at the United Kingdom. And the blue areas are those areas of the world that have reported the B117 UK variant. About the only few places would be the African continent and isolated, areas below the Soviet Union. The South African variant, you can see it borders many countries of Mozambique, Zimbabwe, South Africa, Zambia, some other isolated West African countries. Then you go to Europe, Southeast Asia, and the United States. The South African variant has not been reported in Russia, as of the time this was written, nor has it been detected other than French Guiana in South America and Panama. The Brazilian variant, you can see in the last image here, has affected pretty much all of North and South America, Europe, and India, and some of Scandinavia. Again, I'm sure if we looked in real time, we'd find out some further countries have been added to the list. So the real important question for us, because we're ENT physicians, is what is the impact on our practice? Well, in the office or the clinic, depending upon where we work, we probably increased telehealth, trying to increase our ability to assist patients through telemedicine. We've also had to take huge precautionary measures in sterilization. And we've had to screen patients who are coming to our offices with temperature screening and questionnaires to whether or not they have any symptoms or not. Initially, when COVID first came out, many practices almost shut down completely until we got a good hold as to what this virus was, how it spread, and what are some of the ways we can detect it. As far as hospitals go, every hospital has is different because if they're private hospitals or government run. Those hospitals that are government run will follow the mandate of the hospital. Private hospitals set their own rules. And what we've seen locally here is that hospitals will approve surgery schedules. So for example, if you work in a private hospital that has an can you shut your microphone, please? Thank you. So if you work in a hospital, prior to scheduling surgery, your request will have to go through a hospital board, and they will approve whether or not the surgery you want to do is going to be allowed. And they have set criteria. And we'll go through that because I have a set criteria for otologic surgery, which will be a good example. Okay. Admissions to the hospital. Somebody's got their microphone on and they're typing. I'd appreciate it if you could mute your microphone, please. Thank you. Some hospitals, or let's put it this way, most hospitals at this point do not let anybody in the hospital other than the patient themselves. Family members are generally not allowed in the hospital, especially for surgical procedures. And what they'll do is they'll screen you upon entering the hospital. Sometimes they'll do a temperature check. They'll definitely have a questionnaire for you, and they will screen you. As far as the operating room theater, if you're a scheduled patient for surgery, you will have to be tested 72 hours before surgery. Make sure that you're COVID negative on testing. You need to stay isolated for 3 days until you get to the hospital. And the operating rooms have now increased the laminar flow in rooms to make sure that the ventilation is improved. They've had to alter suctioning so that any secretions do not contaminate. We've also seen changes in anesthesiology techniques. It's called rapid induction. And that means when you roll in the operating room, before anything happens, the patients will be rapidly induced, usually with propofol, and quickly intubated. They don't want people coughing. They don't want any kind of spread of any virus. We're going to look now at Rhinology, because this is by far the real nucleus or epicenter for COVID transmission. And we all know that the virus traditionally has been considered a virus which we inhale. That's why we wear masks. It attached to the globulate cells, the ciliated cells, and even the olfactory bulb neurons in the nose. And as a result of this, we get an alteration in the nasal physiology, such as change in smell and change in taste, because smell and taste are related. But one thing that we don't hear much discussion about is the virus in oral secretions. Sure, it goes in the nose, we swallow it, and it can get into our oral cavity. Well, there is there is COVID virus in the oral mucosa, and this contributes to the loss of taste. So potentially, you could have somebody, you could plug somebody's nose. They've got virus in their sputum, and if you have any exchange to their sputum, um, uh, excuse me, could you shut your microphone off, please? Thank you. Um, so you can have oral COVID virus with acute loss of taste. There are some tests out, such as Saliva Direct, which you can test people's sputum. And then there's also testing that you can do in your office or your home, um, just basic diagnostic testing. So there's really two types of testing. There's diagnostic testing and there's antibody testing. Antibody testing is a much more involved test. You have to take blood and you have to get it assayed in the laboratory. So the number one field in medicine that's been affected by COVID is rhinology. And there's kind of been a transition early on. I think we're starting to get somewhat to a norm now, is to treat non-surgically. And this includes the use of topical medications intranasally. And this is called a neti pot. If you're not familiar with it, you can put medications in it, warm water. There's been an increased use of steroids and iodine for nasal flushing. Now, I talked to a patient who had COVID about 6 weeks ago. He had a cochlear implant on one side about 2 years ago. And in his good ear, post-COVID, he developed ringing. Okay. And this happened, a few weeks after his exposure to COVID. Now, he thought it was from an upper respiratory infection. He was put on antibiotics, high dose steroids, and he got better. He went to the doctor's office, had a tympanogram. As soon as he had the tympanogram, the ringing increased. Another course of steroids, but he feels that cleaning his nose with the neti pot, reducing the mucosal inflammation and reducing the mucus, helped him significantly. And fortunately, he's now back to normal. From Washington University in St. Louis, there is a recent article. And when I say recent, all of our articles are anywhere from, weeks old to maximum 14 months with respect to COVID in the United States. In the Journal American Medical Association, Otolaryngology Head and Neck from September at WashU in St. Louis, they looked at anosmia and dysgeusia. And again, these are rudimentary studies because we knew nothing. And of patients who were COVID positive, who had these symptoms, 50% recovered within 7 to 10 days. Within 3 months, 90% of the patients recovered. And what I'd like at the end of today's lecture, I'd like for some of you who have had COVID to share with us some of your symptoms. What happens when patients get anosmia, again, 90% of the patients will recover within 3 months. But it's been noted, and there's an article in the Allergy and Rhinology Forum, the International Journal from 2020, olfactory training regimen. Now, in your practices, if you see patients who have prolonged difficulty identifying smell, this is really can affect them, especially in homes that use natural gas for the stove and for heating. Um, so they came up with this olfactory uh, training regimen. This is from Stanford University. And it basically says that olfactory training consists of smelling 4 different odors twice a day, every day. And the training usually continues for at least 6 months, and it may last longer. All right. So, what they would do is number one, they'll begin with like the smell of rose, eucalyptus, lemon, and clove. Um, Patients choose one odor and smell it for about 15 seconds while trying to remember what that once smelled like, because they've lost the ability to tell you any of these smells. The patient rests for about 10 seconds, then they do another odor, and they'll repeat this. Okay. And then in about 3 months, they'll change the odors to like menthol, thyme, tangerine, and jasmine. Okay. And then in another 3 months, they'll go to like green tea, bergamot, rosemary, and gardenia. And they'll continue this. And this can go on for a year until patients have the ability to improve from the olfactory training. Out of the Indian Journal of Otolaryngology and Head and Neck Surgery, this is one of the more recent studies and more comprehensive. Uh, the study was done at a primary healthcare center in Doha, Qatar. It was a retrospective study of 141 patients, and the patients were divided into asymptomatic and symptomatic. Of the 141 patients, essentially 25%, okay, had ageusia or anosmia or both. Now, if you look in the literature, I've seen statistics up to 60% of any studied population showing these symptoms. But in this study, it was 25%. 75% of the patients who are post-COVID did not have any symptoms with regards to anosmia or ageusia. And then they broke it down into, these are the 141 patients, the anosmia patients. They looked at gender, they looked at recent travel, they looked at smoking history, they looked at prior nasal disease, and they looked at the level of whether or not they were asymptomatic, mild, moderate, severe. And you can see that none of these factors seem to have played a role in anosmia in 140 in this group, which with the N factor was 141. This is the same study. This time they looked at the ageusia, and exactly the same parameters were noted. Okay. Again, most of the patients were over the age of 30 because those are the patients who are symptomatic up until just recently with COVID. Okay. Male, female, recent travel, smoking, past nasal disease, all had no bearing on the symptoms of ageusia. And the majority, 75% of the patients were essentially asymptomatic. We're going to look at head and neck right now. Now, for those of you that do head and neck, this is probably another main area. It's probably number 2 affected in the medical field. And what we've seen is we've seen hospitals put surgeries on hold, especially in patients who have had well-differentiated thyroid cancer, patients who have pleomorphic adenoma of the parotid, and patients who have hyperparathyroidism who are asymptomatic. These patients are not emergency surgeries. They can be scheduled electively. However, there has been, and I was talking just the other day to colleagues in Italy, they've seen an increase in the stages of advanced head and neck cancer coming into the hospital now, because patients who normally would have come into the hospital might have waited 4 to 6 months longer. So what would have been a stage 3 tumor is now a stage 4 tumor. So we're seeing advanced head and neck cancer surgeries for those that treat head and neck surgery. And again, I would like to hear some of your own personal opinions if you have any on that. And we're dealing with open airways, the larynx, we're dealing with tracheotomies, and personal protective equipment is obviously critical. One of the things we learn in our training is that intubation for patients who are in intensive care units should be reduced for those who are, we believe, are going to be in requiring prolonged ventilation. And what has been, we've seen recently is that those patients who have been having prolonged intubation will get injuries to the glottis, developing glottic webs, glottic stenosis, as well as subglottic stenosis. Now, Vanderbilt University in February, just a month ago, okay, 6 weeks ago, there was a study done, and these are the lessons of laryngeal damage from intubation. And what they looked at, there was acute laryngeal trauma in 57% of patients who were intubated for more than 12 hours. 57%. The chief complaint that they're seeing now from patients who have been in intensive care units and been on intubation is they're complaining of difficulty breathing 3 months post-hospitalization. And what's happening is patients are developing subglottic stenosis. So the recommendation was shorter intubation time, earlier tracheotomy, pre-discharge exam. Prior to leaving the hospital, the patient will have a flexible laryngoscopy done, and then patients will be followed at home with an iPhone questionnaire, and they will be notified on a certain schedule to respond to the questions on the iPhone. Are you developing any change in your voice? Are you having shortness of breath? These are the kind of questions. And this whole process is in evolution still. And here you can see, this is a classic example of we're looking at the vocal cords, and you can see the true and the false cord on the right side. There's a significant amount of ulceration and damage from the endotracheal tube. 2 raw surfaces, and you get a laryngeal, you're going to get a glottic web or potentially glottic stenosis. And here, these are perfect examples of what will develop in people. They'll get dysphonia, change in voice. We have a glottic web on the left side here, and almost a large glottic web with almost complete stenosis on the right side. And this is a classic example of subglottic stenosis. It develops slowly. That's why the patients will, be discharged from the hospital, and then in a 3-month or greater period of time, they'll complain of having difficulty breathing because the amount of air exchange between the larynx and the trachea is now reduced because the opening or the stenotic area is inhibiting this. The area of impact that I think a lot of us would like to talk about would be otology. And what we know is that the middle ear and the mastoid make up part of our respiratory system. Initially, when COVID came out, there was a discussion, do we use steroids? Today, we know that steroids help those patients that are in intensive care units. Initially, it was like, are we causing them to become immunocompromised? And we found out that they have an overactive immune response, and the steroids help to abate that. We treat Bell's palsy and sudden sensory hearing loss with steroids. Otoscopy, probably for safety reasons, if you have a video otoscope, it would be better than using a handheld otoscope because the video otoscope will project on a monitor. You don't get in close contact with the patient. Whereas if you use a Welch Allen handheld otoscope, you know, you're putting your face right up to the face of the patient. And again, you could have a, you know, an asymptomatic, you know, carrier and not even know it. So video otoscopy or using heavy protection and a microscope. We talked about this before, but you know, 48 to 72 hours of preoperative testing and then pre-quarantine prior to surgery. Rapid induction. This is all, when I had my cochlear implant done end of December, these were all the things that I went through. I went through testing 3 days beforehand, stayed at home for 3 days, got into the operating room. I didn't even get off my gurney and I was asleep. The rapid induction is really big. Second is you're seeing some of the anesthesiologists trying to use hypotension, reduce the amount of bleeding. We're also seeing that in some institutions, there's because of the length of surgery, surgical trainees are not getting the surgical experience that they normally would have gotten pre-COVID because people do not want to stay in the operating room for prolonged periods of time. And then there's also the change in the use of equipment. We all know that the surgical drill puts an aerosol with blood and bone into the air. In a laminar flow room, this would be directed to one way. But we've seen more the use of curettes. It's been discussed the use of chisels. In some places like Ukraine, they still use chisels quite a bit. And for those who are not aware of it, there's a thing called a piezoelectric. It's kind of like a cautery unit, but it through an electric current and like these vibrations, it's able to like drill, but it does not put an aerosol in the air. It kind of, you know, I don't even know what the exact way it does it, but I've seen it, and you can look on YouTube and you can see, you know, what piezoelectric does. They've broken down otologic surgery into 4 groups. Top here, we have urgent. In other words, anybody who's got a related life-threatening complication from either the ear disease itself or an intracranial complication will go to surgery immediately. They'll be put on the emergent waiting list. Patients who are a priority, in other words, they need to be operated on within 48 to 72 hours, would be somebody with acute mastoiditis not responding to medical treatment, acute mastoiditis, subperiosteal abscess, any cranial or intracranial complications of cholesteatoma, such as facial nerve paralysis, labyrinthitis, subdural abscess. Those would be indications. Brain abscess, that's another story because you've got to talk about outside of the COVID, you know, the stability of the patient. Barotrauma, where there's evidence of a perilymph fistula and the developing of sensorineural hearing loss. Trauma to the facial nerve, and vestibular schwannomas with brainstem compression. Those are all within 48 to 72 hours. Patients who you can wait a month would be cochlear implantation, would be patients for cochlear implantations who had a history of meningitis, or otologic neoplasm if you're waiting for a special multidisciplinary team. And then patients who can wait 3 weeks would be, or excuse me, 3 months, okay, or 12 weeks, would be uncomplicated cholesteatomas, cochlear implantation for prelingual profound sensorineural hearing loss, implantable hearing aids, non-life-threatening lesions requiring neuro-otologic procedures, and obviously ossiculoplasty, stapes surgery, meatoplasty, and tympanoplasty. In talking again with some colleagues in Italy the other day, one of my colleagues hasn't done a stapes for over 15 months now. As a matter of fact, all he's doing is head and neck surgery. Initially when, and this was like weeks after COVID was discussed as a pandemic, this article came out in the Journal of American Medical Association from the University of Mississippi on the techniques for droplet control. And what they did, they used two drapes, one draping the patient to the microscope, and then the microscope draping and then from the lens draping the microscope. And you can see there's two variations here on the left side and on the right side. It is difficult beyond to try to use a microscope and wear a hood like this doctor's doing. Again, today, almost a little over a year after we've addressed the issue of COVID, we are now operating with personal protective equipment, but it's more of the reliability of the preoperative testing of the patient to know that they do not have COVID. That is probably the measure that is going to give us the most security in doing surgery. There have been case reports of sudden hearing loss post-COVID. I had lunch with a friend of mine who's a neurotologist from House Ear Clinic. He now lives in Boise, Idaho this weekend, and he's seen numerous patients who have developed sudden sensorineural hearing loss. Generally speaking, it's about 1 to 5 patients per 100,000 which develop acute sudden sensorineural hearing loss from etiologies that are unknown. But this is from British Medical Journal. It was a case report. If you guys remember Joe Mangele, he lectured to us about 2 months, maybe 3 months ago. He's one of the authors on this article. And there's a couple of things they've learned from their case reports. Again, we are not sure where the site of injury is. Is it the supporting cells? Is it the inner or outer hair cells? Or is it the neurons in the cochlea that are being affected by this virus? We know that rubella, rubella virus, measles virus, there's a few others that as well have the ability to cause hearing loss. But their learning points were as follows. Sudden onset sensorineural hearing loss can appear following COVID. As with idiopathic sensorineural hearing loss, more research needs to be done to evaluate the benefit of steroids. And screening for hearing loss is suggested in hospital environments to avoid missing the treatment window. And again, that would be, using steroids, maybe even using antithrombolytic agents and decreasing the hearing loss associated morbidity. This was a large review article from the Journal of Audiology, and what they looked at were, and it was in March, which was just last month, from the University of Manchester, as well as in conjunction with King Saud University. And they looked at a bunch of different articles and records. They rejected 850. They used eventually 28 case reports, and 28 case studies were reviewed. And what they found, and this is a list. On the right side, they're looking at cross-sectional, and on the left side, it was case studies. And there's a year that it was done, which again, 2020. And they looked at hearing loss, tinnitus, and vertigo. And if you look on both columns, it says overall quality rating consensus. There were a few that were good. There was a few that were poor. The majority of them were fair. And I guess the reason why in the article they said was because we really don't know the true impact of pre-existing conditions, pre-existing hearing loss, pre-existing tinnitus, and what is the real impact of COVID on patients with a pre-existing condition. And here's the take home from this article. These are the symptoms on the left. We got hearing loss, tinnitus, rotatory vertigo, and otalgia. And from these studies, they found that about 7.6% of patients will have some associated hearing loss with COVID. 14%, almost 15, tinnitus. Another 7 with vertigo, and really high number here, 13% had otalgia. Okay. Traditionally, diseases of the middle ear do not cause otalgia. You know, when we have otalgia, it's either referred pain from glossopharyngeal nerve, patients with oropharyngeal tumors, so, or patients who have intracranial abscess. So generally speaking, cholesteatoma does not create a situation with otalgia. So we're going to move on and talk about long haulers. Now, this is a term that describes anybody who's got COVID symptoms over 6 months. 6 weeks. And they've kind of broken this down into those that have organ damage and those that have non-organ damage. Those patients who have organ damage will be patients who will show evidence of cardiomyopathy, heart failure, pulmonary fibrosis, and we can test all of these. We can do pulmonary function tests, we can do ejection fraction on the heart, we can do EKG, and we can test this and scientifically show that there's been damage to an organ. Unfortunately, there's a lot of patients who don't have organ damage, don't have abnormal tests, but are basically symptomatic. They're saying, we're tired, we're short of breath, but we can't come up with any conclusive test to prove it. What are the mechanisms of injury? It could be direct nerve injury from the COVID virus. It could be an autoimmune response to the cytokinins, or it could be a blood clotting phenomena. We're reducing circulation. Remember, the ear is an end organ. It doesn't have collateral circulation. And 6 or 8 months ago, all you heard in the news was that COVID causes patients to form, clots or emboli. And we talked about pre-existing conditions. In the UK alone, 11% of patients have some form of pre-existing hearing loss, and 17% have some associated tinnitus as well. This is the long hauler study, just came out of Northwestern University in Chicago last month. It was a prospective study of 100 hospitalized COVID patients, the long haulers. 70% were women, average age 43, and 85% of these long haulers, again, patients with symptoms over 6 weeks, had 4 or more neurologic symptoms. And these are some of the ones in orange, like taste disturbances, 59, smell 55, dizziness 47, and tinnitus 29. So neurologic symptoms in these long haulers is very, very common. The non-neurologic symptoms: fatigue, depression, shortness of breath, chest pain, insomnia, high blood pressure, and gastrointestinal disorders. And last of all, would be comorbidities of these. And we've depression, autoimmune disorders, insomnia, lung disease, and headaches. This is what they have found. I know numerous ENT doctors, some of who are included in this lecture today. Lovera from Asuncion, he recently had COVID. Maybe he can tell us a little about his experience. I have a friend in Virginia, ENT doctor, who developed tachycardia. He'd be sitting in his chair and he developed tachycardia, a heart rate up to 180 post-COVID. So there's a lot we don't know. We need to keep developing databases, sharing this knowledge, and trying to understand the pathophysiology that, is the cause for all of this. And I kind of want to just add this little slide about the myths of COVID. COVID is not a Chinese bioweapon. Some people would like to think so, but I think they need a psychiatrist more than they need to talk about the Chinese bioweapon. It was not engineered in a Chinese lab, most likely. COVID is no worse than the flu. COVID is that you can, if you want to compare it strictly to the Spanish flu, as we did in one of the initial slides, sure, it's not. The Spanish flu is one thing, but we're talking about the regular flu, the seasonal flu. COVID is worse than the seasonal flu. There's no need to wear a mask. Okay. There are some politicians that believe that. I tend to disagree. I think that the simplest measure you can do is to wear a mask, because we know the mechanism, we know the science behind the spread of COVID, and it's an aerosol virus that goes from person to person. So to not wear a mask is like, why are you a doctor? You should maybe think about going to become a trash collector instead. The wealthy use the vaccine for profit. There's probably some truth to this. There's a lot of there's numerous large nonprofit organizations that invested in COVID vaccine production, and being that the governments are purchasing this, I'm sure there's some profitability in some of these nonprofits that are managed by wealthy organizations and individuals. Hydroxychloroquine.
A jak chcesz też ten styropianik? Nie.
Shut your
To jest
microphone.
mój, to jest z ziemniaczków, to on jest.
Agata, shut your microphone, please. Thank you. Hydroxychloroquine is effective. It's absolutely ineffective. It's been proven that. And we all know these of some past political figures that, defied science and believed in it. There's also some belief that herd immunity alone will protect us. To get to herd immunity, you need 70% of the population or greater that have had exposure and developed antibodies. That is not going to happen quickly. If it did happen, we'd have probably 20 million people dead before we got there. And the COVID vaccine is unsafe. If you paid attention to the literature coming out of, and the discussion out of Europe within the last month, they were talking about AstraZeneca vaccine causing blood clots. World Health Organization and multiple governments in Europe have reversed that, and they are back on track using the AstraZeneca vaccine. I am not an expert, I don't profess to be, but some of these myths are a little far-fetched. So in summary, what we've seen that COVID has had a significant impact on surgical training. It's increased telemedicine and virtual clinics significantly. It's changed the way we sterilize in our office. It changes the way we sterilize in the operating room. We've had to take measures to change airflow, especially in operating rooms. The surgical scheduling for non-emergency is significantly postponed, and it is imperative that we test all of our patients perioperatively for COVID virus. You should be doing temperature checks and questionnaires for all patients who are coming into your clinics and offices, irrespective of them being asymptomatic. The other thing we've seen, and I didn't mention this earlier, but there was a discussion on the use of the endoscope for ear surgery, because with the microscope, we have to get closer to the patient. With the endoscope, and we have everything on a monitor, we're not close to the patient, exposure would be reduced. But again, we all need to remember one thing: endoscopic ear surgery has its limitations. When you have a cholesteatoma that is in the mastoid middle ear cleft, and we're not dealing with a simple perforation or a small epitympanic cholesteatoma, the endoscope is not the tool to use. And then I mentioned earlier some alternative tools such as piezoelectric, more use of a curette, and chisel to remove disease would reduce the amount of aerosol viral particle and the less chance for infection. So I thought it was interesting and important today to look at our practice in ENT, look at the impact of COVID virus and,
Przypaliłam się.
address that. I'd like for those of you who had COVID to, take an opportunity to share any of the symptoms you've had and open it up for further discussion. Again, none of us know much more than what we read and what the scientific community has given us. So,
this year seems to be quite notorious compared to years actually.
we're having a hard time hearing you. Let me see here. Jose, I can't hear you one bit. It's all broken up. All broken up. Give it a minute. Jose Lovera, are you there? Lovera. Okay, how about anybody else? Anybody who's had COVID and has a good internet connection, I'd appreciate it if you would try to share some of your symptoms with us so that we can all, get an appreciation.
Hi, Richard.
Hi, Roman. How you doing today? Roman, can you please share with us some of your symptoms? Roman's from Ukraine. He had COVID a couple months ago.
Yeah, I had COVID in mid November last year, and basically I had symptoms, like symptoms that I could feel for about 3 weeks. For about 10 days, I had fever up to 39 degrees Celsius, 39.5, which wasn't going down even with paracetamol or ibuprofen. So it was really, I sort of had kind of hallucinations at night because of the fever. And another major complaint was fatigue. So I couldn't talk on the phone at that time. So it was really, I was exhausted. And these were my main concerns. I didn't have loss of smell or loss of taste. I mean, my senses were a bit decreased, but again, I didn't lose them totally. But again, at that time, I didn't really felt like eating a lot. So I sort of made myself drink fluids. But, though my wife, she had COVID last March, and she had mild fever, and she had loss of taste and loss of smell for 2 weeks, and that's it. So she had mild, her condition was quite mild. But again, I'm still having some post-COVID complications with my heart, with my cardiovascular system. And it's difficult to climb the stairs. So if I walk to the third floor, I have shortness of breath. And I'm doing ECG from every now and then. And today I had another one. I'm doing ultrasonography tomorrow because they suspect I might have myocarditis. So can't do a lot of exercise. This tiredness is there most of the time. So I still have some post-COVID symptoms, I would call it that way, or some leftover symptoms after the disease. Though I didn't use in my treatment while I was ill, I did a few lab tests. So I did a C-reactive protein, general chemistry, hematology, but also C-reactive protein, procalcitonin, and the D-dimer. So that were my main, markers whether to use. And certain medications are not. So basically, in my treatment, I had a few injections of dexamethasone, IM, and paracetamol, ibuprofen, and I had inhalations with some of the local steroids that people use for chronic for pulmonary conditions. So basically, that was all the treatment I received, and I stayed at home. I wasn't admitted to the hospital.
Very good. Thank you for letting us know that. Yeah, I've heard of, like I said, my friend had tachycardia. You've got maybe pericarditis. You've had fatigue. Um, you know, everybody's got a story. Let's see if we can get Lovera. Lovera from I don't know where he disappeared to. He seems to be there, but he just recently had COVID. Anybody else had COVID who would like to share some of their story with us? Anybody seen any patients with sudden hearing loss in their practices, vertigo or tinnitus associated with COVID? Nobody's going to answer my question. Well, that's blessings for you today. If that's,
Richard, I can add another one.
yeah, please, Roman, go ahead.
Yeah, because like almost all of my family had COVID. So my mother had COVID and she was admitted to the hospital. Okay.
Roman, go ahead. I'm sorry.
Yeah, and my brother, he was admitted to the ICU. He was almost intubated. So he started it by having, like a mild condition, some fever, cough, but then he got worse and he was admitted to the hospital, and then he had to be transferred to the ICU. And there was a point of time that the doctors were actually thinking of intubating him because he had he had the total pulmonary damage on the on the CT scan. But again, fortunately, he came out of that condition and he got better. But again, the day he was transferred to the regular ward, 2 people died at his ICU ward where he was. So that was quite stressful and scary. So yeah, and my parents actually got vaccinated today.
Roman, is your brother have any does he have any long hauler problems? Is he short of breath, fatigue?
So I saw him 2 weeks ago,
Mhm.
or about 2 weeks ago, 1 week ago. So he wasn't complaining about anything at that time. So but he takes it easy. So you can't have a lot of exercises after that because you just physically can't do that. So he does have some tiredness and fatigue, but his breathing is normal, so he feels himself all right.
Mm-hmm. Talking about tracheotomy, a lot of doctors don't want to do tracheotomy. They don't want to get exposed to the COVID because they know they're dealing with a patient in an intensive care unit. So the doctors don't want to do it, and the patients are suffering because they're going to develop, high risk of developing subglottic stenosis, or it's not a happy situation. We used to do tracheotomies at bedsides with nothing more than a pair of gloves pre-COVID. Now, it's a completely different world. More patients need to be trached now than ever, but they're not getting it.
Yeah, and people, I mean, at our hospital, pretty much most of the doctors got COVID already, so they take it easier than people who didn't have it. But again, every time you go and do a case, it's you're at the higher risk of being exposed, and now there are no planned surgeries at the hospital, and we haven't had any since last March. So as of today, it's just urgent cases and emergency medicine at the hospital. That's it.
Right. Thank you, Roman. Nega, if you're there, Nega's from Ethiopia. Nega was here. He got vaccinated in the United States about 6 weeks ago. In Ethiopia, from my understanding, it's difficult to get vaccinated in Ethiopia. in Cuba. Cuba is a tiny country. Most of you know Fidel Castro by name. Cuba has not only made their own vaccine, but Cuba is producing their own vaccine for the Cuban population and for distribution to other countries in the world. And I think it gives a lot of respect for the Cubans. What else? I'm not sure. Does anybody want to talk about vaccination in their country, or have any contributing comments? If not, we're going to call this the end of the lecture, and I appreciate everybody joining. Next week's lecture, I don't have one planned. So if somebody is on this conference and would like to give a lecture on their country and ENT training or on a particular subject matter, please do so. If not, next week will be a vacation for everybody, okay? I appreciate everybody joining here. Karen, hi so far, thank God. I don't have COVID and no one in my family, or maybe we are, or we're asymptomatic. That's from Karen M. Karen, thank you. Karen, where are you from again? You can type it in there if you're still
Hi,
there.
Richard. I am from Nicaragua.
Okay, great. Karen's from Nicaragua, Central America. Karen, tell us something. What's the status of vaccinations in Nicaragua right now?
Right now, the government start with the vaccine only for people who has cancer and only the people who has renal disease.
Okay.
And the vaccine that they are using is Sputnik, and the other one is Covishield from India.
Okay. Sputnik's from Russia, and the other one is from India.
Yeah.
Okay, good, good. Well, I hope they get a lot of it, and I hope they get it quick. I appreciate that. For those of you that do speak Spanish, this Saturday, the webinar is going to be in Spanish only for Latin American countries. Karen, do you have that information?
No, I don't have it. If you can share with me, thank you.
Yeah, I'll send it to you. Okay.
Thank you.
All right, everybody. Listen, thank you for joining. Have a good week and stay COVID free. That's all I can tell you. All right. Have a pleasant day. Bye-bye.